This video is going to be a continuation of our coronary artery disease and chronic stable angina / variant angina lecture. We're going to begin looking now at ACS. We've talked about the fact that we have coronary artery disease, and we can kind of divide that up into this acute coronary syndrome process. It's kind of exactly what it sounds like. You have an acute situation, you have an acute occlusion or blockage or lack of perfusion to your coronary arteries. This sudden interruption of oxygenation causes ischemia, which results in injury. It can lead to tissue necrosis, which leads to all of those other bad things that we're going to talk about. Hypertensive crisis. It can lead to shock. It can lead to heart failure, cardiomyopathies. So we're going to look at how, from an acute situation, I need to proceed, and then how we're going to treat this long term. So a couple of the things that we are going to use to differentiate chronic angina, that chronic stable angina, chronic ischemia, from a myocardial infarction. We see it generally, when we talked about chronic stable angina, we knew that it was going to be precipitated by exertion or stress, right? There is an underlying reason that I'm having chest pain. Versus a myocardial infarction, it occurs without anything. During rest, often in the morning. You see it in the news when you have those really fit, healthy people that had an MI. Usually they're out doing something early in the morning and exercising, and they have this massive MI, and they're unable to get enough help, and they end up passing away. We see that chronic angina is relieved by rest or nitro. We talked about that in the previous lecture. And we're talking now about the pain, the angina, the ischemia. So although we're going to give nitro to both, that pain, that ischemia, is only going to be relieved with opioids like morphine. So when we talked about the MONA of our treatment plan, that pain is going to continue regardless of oxygenation and regardless of nitroglycerin, because you do have that acute blockage. So that morphine really is the only thing that's going to take away that pain for a client who is truly experiencing an MI. For chronic stable angina as well, usually you don't have activation of the entire sympathetic nervous system. You can end up with tachypnea and tachycardia, but we don't progress into that nausea, the epigastric distress, the dyspnea, anxiety, the diaphoresis. Those are generally going to be more associated. Remember, we're talking typical presentations, not atypical presentations of an MI. But the biggest one, the easiest one, is probably the length. We teach our clients with chronic stable angina about taking 3 nitroglycerins, about taking that aspirin, either the 81 milligrams or the 325 milligrams. With a true MI, that pain is going to last longer than that prescribed amount of time. And again, when we said in the previous video, it's important to seek early treatment, this is why. I don't know if after that third tab of nitro that the chest pain is going to go away. And the entire time that I am delaying care, I have the potential for tissue necrosis, tissue death. In the kind of little GIF that we see down here, this client's heart rate is 69, but I can definitely see ST elevation. That S wave does not come back to the baseline, and it goes over about, a little bit more than 3/5 of the way down, but it definitely does not ever return to that isometric line. So we've talked about the signs and symptoms, typical presentations versus atypical presentations, and that's important for us. Again, that time piece is going to be really important. Signs and symptoms: sudden crushing, radiating chest pain that continues despite rest and medications. Remember that opioid is the only thing that's going to get rid of the pain. You have this acute shortness of breath. You can have nausea, vomiting, diaphoresis. You have changes to your skin color and temperature. It's going to radiate to your left arm, mid-back, shoulder. It may present as just heartburn. And that's why a lot of these folks don't seek immediate treatment, because they don't think that it's a myocardial infarction. So that's a lot of patient teaching that we have to do once we have identified that that client has coronary artery disease. And again, we do see that women can present differently. They'll complain of just a generalized malaise, a little fatigue. I've got some pain between my shoulder blades. I slept wrong. A little bit of shortness of breath. I'm just getting old. Whatever it may be, we're still going to do the things that we need to do to identify that client's risk for and potential of having a myocardial infarction. So a couple of things, right, we can help use to identify this information is you want to check your pulse, right? It's persistent chest pain, upset stomach, lightheadedness, shortness of breath, and then you throw in that excessive sweating. We've talked about in the past that in this kind of situation, if the client is unresponsive, we're going to initiate those steps in CPR. Even in the healthcare setting, it's that process of, hey, are you okay? I'm going to watch for breathing while checking the carotid pulse. Remember, don't check both carotid pulses. It's one. And you're going to start CPR and then check an airway, give breaths if possible. Obviously, during that time, at the beginning of it in the hospital, you're going to push the button to call for help or holler out or however you want to do it. What you don't want to do is to take somebody else's opinion. I've been in the situation where I've been called to a code situation. We're like, hey, does she have a pulse? The nurse says, no, she doesn't have a pulse. And we start CPR and the client pops awake on us because we just put a lot of pressure on him, right? Caused a lot of pain. And we just didn't do a thorough assessment. It's okay to call and ask for help, but make sure that if you're saying that they are pulseless, that they are truly pulseless. So if a client does present to chest pain, there's things that I want to do. And again, this is kind of in that order situation since we know that NCLEX really likes those. What are you going to do first or what's the priority type of thing? Sit them upright. Give supplemental oxygen. You got 10 minutes to obtain a 12-lead ECG. We can give sublingual nitro and aspirin. Remember, we've got to get that ordered. We've got to get it out of the MAR, whatever. Headache can be a common side effect of nitrate therapy, so we can expect the administration of acetaminophen if they do have a headache. We want to make sure that they have more than one, so multiple IV accesses. Usually NCLEX says like 2, because you're probably going to expect to give them antidysrhythmics, antihypertensives, pain medications. You could give them anticoagulant, continuous infusions. Then we're going to do morphine. Remember, pain is Maslow's, so it's pretty far down the list. We get really caught up in that pain, but it's airway, breathing, circulation, changes in LOC, then Maslow's, and then ADPI. And then finally, we're going to check those laboratory values. We are going to concern ourselves with troponins, but remember, you have the cardiac enzymes, CK, CKMB, myoglobin. In this type of situation, I'm going to throw in the fact that we could also obtain a BNP. When we talk about heart failure, we're going to look at a B-type natriuretic peptide. That's the marker for heart failure. Because we want to figure out, is this true hypoxic ischemia or is this demand ischemia? And what I mean is you have a true interruption of the blood flow through the coronary arteries versus I've got a bad pump that's not getting enough blood to the coronary arteries. Because remember, our goal here is to treat the signs and symptoms and to treat the underlying cause. If you are experiencing decreased perfusion because of heart failure, you can still have ST elevation or T-wave inversion or ST depression and all that other great stuff. But if you don't fix that pump, you're never going to fix that lack of oxygenation. But we're going to assume that right now, because we're talking about an MI, that the troponin is going to be the definitive test or the definitive lab test for an MI. So here again, we kind of see the breakdown. We've seen Mona before: morphine, oxygen, nitroglycerin, aspirin. You can expect maybe some sort of thrombolytics. Remember we talked about TPA, tissue plasmin activator, altipase, streptokinase. TNK now is being used more and more in clients with strokes. I could expect to send them to the cath lab. And remember that cath lab is kind of interwoven when we talk about a percutaneous coronary intervention or a coronary angiography. Those are going to usually happen in the cath lab. So we could expect some of those sort of interventions where we're going in and doing a stent, where we're going in and doing a CABG, a coronary artery bypass graft, where we can go in and do an endarterectomy, where we're cutting out that area of blockage or pushing that blockage, the plaque to the sides of the coronary artery using a balloon. Any number of things that probably aren't basic nursing, but just know that those options are available to us depending on the severity of the occlusion. We could start them on continuous heparin, right? Because if it's due to a clot, we don't want the clot to get bigger. And obviously it's rest, right? So rest with nitro. Then we're probably going to add a beta blocker because it's going to end up being Monab and then stars, as well as a calcium channel blocker if they're in some sort of dysrhythmia or something, or just because, remember, we said calcium channel blockers are shown to be effective at promoting coronary artery vasodilation. So here's just the other kind of breakdown, the mnemonic to help you remember. It's Monab-stars. So these are things that I could expect to do in my plan or my management of care of a client with an MI. It's morphine, oxygen, nitroglycerin, aspirin, ACE inhibitors. And again, ACE inhibitors and beta blockers are probably going to come later, probably at discharge. We've talked about the fact that ACE inhibitors prevent remodeling. We want to decrease that client's risk for heart failure. Again, with an ACE inhibitor, watch for the prill cough, which nobody really cares about because you'll just switch to an ARB, but also the fact that they hold on to potassium. And then a beta blocker. And a beta blocker, we've talked about side effects of, they interfere with your albuterol. They mask the signs and symptoms of hypoglycemia because we know a lot of these clients are diabetic, and they are also at risk for bronchospasms. Sedatives, because the client's going to be anxious, they're going to be in pain. We may need to send them down to some sort of procedure like thrombolytic therapy. You may need to start them on an anticoagulant. You're going to provide rest. You're going to promote rest. And then stool softeners, because if we start bearing down, that has a response. It's part of your cranial nerves, and that will actually stimulate a tachycardia, and that could send you into a tachydysrhythmia, which could lead to a lack of perfusion. So again, we're going to do things that are easy to promote coronary artery perfusion. We said earlier that people don't die because of the MI. They die because of the lethal dysrhythmia. And up in the right-hand corner, we see a 6-second strip of ventricular tachycardia. Tall, bizarre, wide QRSs. Heart rate is really fast. We've got to do some emergency care, depending on if it's pulseless or with a pulse, if they're symptomatic or asymptomatic. It's just the deadly dysrhythmia is going to kill you if you don't fix it. Signs and symptoms of shock. We say initially you're going to see an elevated heart rate and blood pressure, and then if we don't do things long term, you're going to have a decrease in that blood pressure, and then you're going to have that ultimate decrease in cardiac output, which is obviously going to make your perfusion worse. So we're going to think shock. Changes in the color and temperature of your skin. You could have fluid accumulate in the lungs, so you end up with pulmonary edema. And then if it continues to back up, so now we have signs and symptoms of both left-sided heart failure and right-sided heart failure. And obviously, probably one of the quickest things that you're going to experience with a decrease in cardiac output is a change in LOC. From an ED perspective, the client comes in, they complain of chest pain. We're going to do the simple things first, right? Put them on oxygen, whatever we can do. We know that we have time limit rules. So when we talk about OPQRST, we are talking about 10 minutes. So if I ask you, hey, when did you get here? And you're complaining of chest pain, I've got 10 minutes to get that 12-lead ECG. And that's all part of the triage process. So we want to make sure that we are being as close to those time frames as possible, because when we talk more, we got 10 minutes from the door to the ECG, and then we need to send them down to the cath lab for a STEMI, and there's time limits for that as well. So we want to reestablish perfusion. So I have 6 hours, and it's from the onset of signs and symptoms for the use of thrombolytics. Now, again, this is what NCLEX's rule is, so this is the rule you need to understand. It's 6 hours from the onset, and that's why we do OPQRST. So 6 hours for the use of thrombolytics, but it's 30 minutes. So included in that 6-hour time frame is I got from the time they walk in the door, it's 10 minutes for the ECG, and it's 30 minutes to get in that thrombolytic therapy, that TPA. And then if it's a STEMI, because the STEMIs are the ones most likely to go to the cath lab first, or emergently, I should say, then you have 90 minutes from the time that they enter the door to send them down to the cath lab for that PCI, that percutaneous coronary intervention, to do some sort of therapy. And that's, we say that the people are having issues in that first 2 hours of chest pain, and that's why you hear all the time code blues in the cath lab. And it's kind of counterintuitive because you've got doctors and you've got nurses and they have easy access, but they need a little more help. And we need to make sure that we're addressing those signs and symptoms. Things have now progressed to those lethal dysrhythmias, and they want a little more help. So again, just to review, I know we have talked about this constantly. Here, I need to be able to identify, it's going to be on the test, I promise you, and it's likely to be on NCLEX either in a scenario or as a question or something. You need to be able to identify ST elevation. So here we can knock off my P. I can definitely see this client has a Q. I can see that they have an R, and here I have an S and a T. This is normal. This is baseline. And here I see the same things, only I definitely see that this S does not return to baseline. It is elevated. This client is having an ST elevated myocardial infarction. That's a STEMI. Just because you don't have ST elevation does not mean you are not having a heart attack, right? And we don't just take those seriously. We take STEMIs and NSTEMIs, or non-STEMIs, non-ST elevated myocardial infarctions. And instead of seeing this elevation process here, what you may see is ST segment, right? This is the ST segment depression. So it's below baseline. It's below that isometric line. Notice the T wave is perfectly upright like it should be. And then I need to ask myself, is this new? Is it acute? Because ST depression and T wave now, this one is inverted. Depression and inversion just mean the potential for death or injury, and those are bad. Ask yourself, is it acute or is it a chronic? We're still going to go through the processes of getting some cardiac enzymes. They could still possibly be sent down to the cath lab, but these clients may be more than likely treatable without going to the cath lab initially. It's not as emergent as a STEMI, and that's going to depend on your healthcare provider as well. I don't get into the logistics of it, but both of them are still myocardial infarctions. So we're going to treat it as such. So here we see a really bad situation. It's a little longer than a 6-second strip. Remember, our 6-second strips are annotated with our 3-second little tick marks, and that's our 6 seconds. So I can see that their heart rate is about 50, probably 59-ish if I would throw into another QRS on there somewhere. I can definitely see ST elevation. All right, so this definitely is not coming back to baseline. But what I also see is I see some rando Ps without QRSs, and we know that that is some sort of heart block when there's not a QRS associated with the P. So I have it here, I have it here, not here, not here, I have it here. So we know that that is some sort of heart block. So it's already a Brady arrhythmia. We talked about the fact that most heart blocks are going to be Brady arrhythmias. All right, so my job is to restore perfusion, and we know that if I have a decrease in heart rate, that's going to affect cardiac output, because heart rate times stroke volume equals cardiac output. So now we got a couple of things to look at. What's causing the heart block and what's causing the ST elevation? Is it a lack of perfusion? Is it a pump issue? Or is it a true myocardial infarction? So it would be nice if everything presented with, oh, it's just ST elevation. It doesn't happen like that in the real world. You've got to be able to recognize multiple things at the same time to provide good client-centered care. Okay, so we've talked about troponin I's and T's. That's a positive value. Anything that's elevated, we're going to have to get those troponin levels every 6 hours. We can see down on our illustration that from the initial onset of chest pain, you see the rise and fall of the troponin levels. It's kind of like this bell curve, right? It's going up, it's tabletopping, and then after usually 18 hours or so, it starts to go back down, and hopefully, notice it doesn't return all the way to 0. Hopefully we get a number close to 0. And that's what I would expect to see for my troponins. Again, myoglobin, CKMBs, yes, they're cardiac enzymes, and yes, they could be correct answers if it's like a multiple choice question for MI. We've talked about that I would expect a B and P, right? Because we need to determine, is this from occlusion or is this demand ischemia when we talk about heart failure? Things that we're going to consider doing, it's frequent vital signs. And again, I don't worry so much about the timetable because I would just expect that's going to be part of your institution's policies and procedures. I'm going to do serial ECGs. So that means more than one. Remember, we talked about the fact that a 12-lead ECG is just a snapshot in whatever time frame. So if I do that ECG at 1 o'clock, it's only the 1 o'clock picture that I'm looking at. But I would still expect that client to be on continuous cardiac monitoring, telemetry. We're still going to go through the processes of OPQRST, and we're going to treat those things. We're still going to make sure that we're measuring our I's and O's and looking at our hourly urine output, because that client is now at increased risk for developing heart failure and shock and all those other lethal dysrhythmias that we've talked about. So it's just your normal cardiac interventions. It's just more acutely focused. You could still expect, cardiac enzymes, your electrolytes, ABGs. We don't talk a whole lot about ABGs because this is a cardiac test, but it's actually going to tell me about perfusion. We've looked at lactated acid levels in the past because you could end up in some sort of acidosis because of the way that you have breakdown of your red blood cells due to injury, and then now you have hyperkalemia. We still expect to give oxygen, IV access, and promote energy conservation. And then again, we see the breakdown now here in this illustration of they're going to the cath lab. They're either going to get a PCI, coronary angiography, cath lab, whatever, or they're going to get a CABG. If I can push that plaque to the side, if I can stent that plaque, it's a PCI. If that plaque is so thick and so viscous that nothing that I do is going to get me through that, we're going to have to probably send that client to the floor and to schedule them to have a CABG. So that means that client is going to be probably in constant pain. And I've seen this where we've had clients who are not responsive to any type of therapy and weren't candidates for PCI and who are on a floor and who are on a continuous heparin drip as well as a continuous nitroglycerin drip, as well as they're getting morphine every X amount of time because they're in constant pain. So you have to think about that. What do I need to do for this client if they're not really a candidate for a PCI? And what do I need to do to get them ready for a CABG? We've talked about fibrinolytic therapy, the TPA, tissue plasminogen activator, alteplase, streptokinase, TNK, whatever it may be. If I'm giving that in a hospital situation, you're going to administer that. And the biggest thing that I need to monitor for now is bleeding. But a couple other things is if I'm giving it because you're having ST elevation, remember those fibrinolytic therapies, the clot busters, are going to break up the clot. You should see that marker of reperfusion, that ST segment, hopefully returns to close to or to baseline. If it doesn't work, we're probably going to have to go in and pull that clot out. So they're going to end up in the cath lab anyway. Long term, these clients, we may have to do a stress test. Like we said before, we don't know that we have coronary artery disease or we don't have chronic stable angina until we come in with this acute situation. We can schedule them outpatient for a stress test, either exercise or medications. We've talked about that in our diagnostic studies lecture. Here's kind of an example of what happens in the cath lab, right? We can do a coronary angiogram, all right? It's cardiac cath. Those kind of terms are used interchangeably a lot by nurses. They go to the cath lab for the coronary angiogram, which is in and of itself a percutaneous coronary intervention. So we're going to insert a catheter usually into the femoral artery, but we can do the brachial or radial, and thread it to the right side of the heart and over to the left side of the heart, because then we'll thread it out the aortic valve and into the coronary arteries. And here in this example, right, they're threading that catheter through what looks to be the right femoral artery. You see how they kind of have that right brachial artery highlighted as well. We're going to inject that dye, that contrast, so that we can visualize the coronary artery, so we can visualize blood flow. We're going to look for that area of occlusion. And here for this PCI, it looks like we're going to insert a stent. So usually these are drug-eluting stents, which basically means that they are going to open up your artery. They're going to push that plaque to the sides of the wall there. So we can assume before that this plaque in picture 4 here was like this. Sorry, red's not showing up very well. But now you see over here how this balloon is pushing this plaque to the sides of the wall. That's not taking the plaque away, right? But it is stenting it. And unfortunately, with stents, we know that once you have one, you're probably going to end up with more than one, especially if you're non-compliant. So again, this goes back to your patient teaching. We have to make sure that if they are doing stents, we're going to promote smoking cessation, that we're going to teach them to don't drink, to diet, to exercise. So a couple of things we've repeated. Remember, the cardiac catheterization is the gold standard, right? The coronary angiography is the gold standard. It allows for visualization of the coronary arteries. It allows us to see blood flow. We're going to use probably a contrast media, so check for allergies. We're going to insert it through an artery, so their big issue is going to be bleeding. We've talked about what to do post cardiac cath, or we're coming in, we're making sure we're monitoring vital signs, checking LOCs, looking at the site for bleeding, assessing distal pulses. But the big thing from an MI perspective is if I send you to the cath lab and they send you back to me, or I'm on the cardiac step down unit, the cardiac ICU, whatever, and you start complaining of chest pain again, that probably means that that therapy was not effective, and we're going to probably end up sending you straight back to the cath lab. Sometimes it can be just because you're having a reperfusion dysrhythmia. It's just like your body wasn't used to all that oxygen, because for a long time we didn't know we had CAD, so your body compensated. And now that you have all of this oxygen coming to your coronary arteries, they start going, hey, what's happening? I don't understand this whole process. And they end up in some sort of dysrhythmia. Hopefully it's not a reocclusion, but that can happen. That reocclusion can happen. So here kind of we see the imaging of what to expect. We see this coronary artery. I can definitely see that it has an area of occlusion. And I'm going to go through and I'm either going to stent or I'm going to use clot busters. It doesn't look like there's a clot from the first issue, so I'm going to assume that they either did a revascularization or a stenting. But we can see now how that definitely improved blood flow to that coronary artery. So here kind of is what happens inside your coronary artery. You see this balloon inflating, it's pushing the stent out, and then that stent is going to stay extended, and then we'll deflate the balloon and pull the balloon back. Talked about post-procedure management, bed rest. You want to make sure that they keep that leg straight. Again, I'm not necessarily concerned about time frames because it's going to be a little bit different for everybody else. But monitor vital signs and distal pulses. Make sure you probably realize that not immediately, but over the next day or so, we're going to start them on anticoagulant and antiplatelet therapy. Long term, we've talked about the medications, the nitrates, the calcium channel blockers, the aspirin, and clopidogrel. You can be on all of those at once. They all work differently. And then you're going to add in a beta blocker and an ACE inhibitor. If you end up with a pearl cough, they'll change you from an ACE inhibitor to an ARB. And then, of course, we want to assess for complications of the medications and the procedures, and to make sure that we're not experiencing any kind of reperfusion dysrhythmias or further chest pain to tell us our interventions weren't effective. So here's a breakdown of those drug therapies. Just again, it kind of tells you what each one does. Sending clients home with nitroglycerin. Headache is going to be your big one. Non-compliance is probably going to be a big one. Because we're probably adding a beta blocker in there, and a lot of our clients tell us that they don't like the way that it makes them feel. It interferes with certain other things that we are aware of. So we have to make sure that we're doing a lot of patient teaching. You do have sublingual, you have spray, you have ointment, and you have IV. IV is obviously going to be in the hospital situation. Usually it's at sodium nitroprusside. But again, that sodium nitroprusside basically, I think, turns into like cyanide with long-term use. So you want to be careful. We're going to teach them about the tab and making sure we place it under the tongue, that we're not drinking, swallowing the pill. You can use fluid to help, but it's a sublingual tab. But they also do have an option long-term for isosorbide mononitrate or dinitrate. Again, I'm not going to get into the logistics of who's going to be prescribed what, but you do have the option for a long-term PO medication or a long-term sublingual medication as a prescribed medication rather than rather as a scheduled medication rather than a PRN medication. But it's in the name. So if you look at the nitrate portion of the isosorbide, it's not that big of a deal. We understand what nitrates do. They promote vasodilation. You can end up with a headache. You can take some Tylenol. Teach them to rise and slowly because it will have an effect on your blood pressure and all those other things we talked about with nitrate. If we're going to use nitro tabs, the sublingual kind, you're going to do patient teaching. You see the picture of the bottle up there. Notice it's brown to protect it from light. We want to keep it in a dark, cool place. Don't carry it around in your pants pockets. That's not going to work, right? Store it away from the light and heat as much as possible. So that includes body heat. You should always have some with you. It should be easily accessible. You want to teach them to stop the activity and rest because we're hoping that it's chronic stable angina versus unstable angina. You're going to teach them to repeat it every 5 minutes times 3. You're going to teach them about using it prophylactically before exercise. And then remember, we said we're going to call for help during or immediately after that first dose, because usually if the first dose isn't effective, then the second one probably isn't going to be effective either if you're actually experiencing a true myocardial infarction. And then the other one is that these, once they're open, should be replaced every 6 months. So obviously you have a cost thing there. You have people who may not become compliant with that, but lots of patient teaching for sublingual nitro. Transdermal nitrates, these are probably either in a patch that we have to do. So it's the paper that we squeeze the 1 inch or the 1/2 inch or the 2 inches of nitro on. So we have to teach them about making sure that they're not touching it with their hands, that they're cleaning that area, because this does promote vasodilation. It will decrease your blood pressure. It will cause you to be dizzy. It will cause a headache. Don't see this generally prescribed a whole lot anymore for clients who are being sent home. Where I would expect to see it is more along the lines of somebody who is in a skilled nursing facility or an acute rehab facility, right? We're going to show them how to apply it. It may be used upon the chest, abdomen, lower, upper arms. We want to rotate sites. Don't rub the ointment into the skin. Literally, once you measure it out, you're going to attach it with that piece of paper and tape that piece of paper, rotate sites. Once you're going to change that site, usually it's, Q12 hours or whatever they wear it for, and then you change that site the next time. You want to make sure you clean that old site because otherwise you're going to leave nitro cream there, and that's going to make your hypotension worse. Make sure we're teaching them about asking for help with ambulation and teaching them about the whole, orthostatic hypotensions type of deal. Place it on a hairless area of the skin. We talked about rotating sites, washing the area, and hopefully we want to make sure that we're medication free between 10 to 12 hours a day. So patient teaching this isn't something you're going to wear for 24 hours. If we're going to use nitroglycerin continuously, you're going to start them slow, usually around 5 micrograms a minute. And then you're going to titrate it gradually until you achieve the desired response or until you start to suffer bad consequences. So if it starts to drop your blood pressure or you start having changes in LOC, we may have to consider something else. Again, usually this will be for our clients who are probably experiencing some sort of chest pain. They are not a candidate for a PCI or for stenting or for any type of angiography, and we're getting them ready for a CABG. And unfortunately, you do have some clients that aren't even candidates for CABGs because there's so much occlusion in their coronary arteries. But the big piece here is that you are going to be making sure that you are taking vital signs as frequently as prescribed because it's a continuous infusion of a nitro medication. So here, we're kind of looking at this client. This is a 12, well, kind of a 12 lead. We see I have a couple of images with ST elevation and how it looks different in each lead. We've said as long as I have a QRS, I don't care which way it goes. If it goes this way, fine. If it goes this way, fine, because we notice that those are different leads that I'm looking at, right? So it's a different visualization of the heart. It's like, are you sitting in the front of the room or are you sitting behind the professor? And that's what your image is. But you have to be able to recognize, here I have ST segment depression. Here it's a different lead, but it looks differently here, but it's still, now it's ST depression, but it's because it's viewed differently, it looks a little different. And once you get into your critical care courses, you'll get more information about, it's 2 millimeters above the baseline or whatever number that they're going to use. But you have to be able to look at this and say, okay, even though the client isn't experiencing or telling me that they're having chest pain, this is an abnormal ECG, and I need to do further diagnostic testing. We've talked about the side effects of nitrates. Headaches are common. Dizziness, vertigo, weakness, hypotension, flushing. We have severe reactions with long-term use. And again, the whole evaluation is that we should have no chest pain. With beta blockers, we're going to kind of observe for the 4Bs. Bradycardia, we know we should be taking apical pulses. If they're a diabetic, we're going to be looking at those blood glucoses because it masks the signs and symptoms of hypoglycemia, bronchospasms, and of course your blood pressure. The big reason we're using beta blockers is, remember that they decrease how much oxygen your heart needs to do the same amount of work. They decrease myocardial O2 consumption. Anti-anginals, these are going to be, again, your calcium channel blockers, and then you'll throw in a couple other if it's associated with dysrhythmia. So mostly you're going to be looking at your ipines, amlodipine, nicardipine, nifedipine. But if you have a lack of perfusion from a dysrhythmia, you can expect like a diltiazem or a verapamil. These are going to help slow down your heart rate. But the big issues with these are going to be associated with asking for help, right? Headache, because of decreased perfusion. They will elongate your PRI, so that's a heart block. And we will have a low heart rate because it slows down electricity, and you'll have a low blood pressure. So you have to be careful with making sure we're observing for those signs and symptoms. ACE inhibitors, we've talked about the fact that they're going to be given to prevent ventricular remodeling. Again, they're going to have an effect on your blood pressure. And then we need to be watchful of hyperkalemia and angioedema. So I have now this swelling around my face and throat, and that would be an occluded airway. So that would be a really bad adverse sign and symptom of ACE inhibitors. Your thrombolytics for your acute situations, we've talked about the big thing there is that ST segment, or however we're measuring that they're not perfusing the coronary arteries, should return to baseline. But bleeding is the big one. Your antiplatelets and anticoagulants. So your aspirin and your clopidogrel are your antiplatelets. You're still going to be able to look at their platelets. You're still going to do teaching about bleeding. And then anticoagulants, I would expect maybe to start them off on heparin or enoxaparin, either subcutaneously or continuously for heparin. Enoxaparin is going to be an injection. but we need to do our, check our PTTs, check our platelets because of the increased risk of hits. Our statins are going to be used to decrease their cholesterol. Remember, we're looking for that number between our cholesterol, our HDL, and our LDL, and our triglycerides. Just remember with statins, we have that increased risk of rhabdomyolysis, so we got to do some patient teaching. And that is basically the basics of treating myocardial infarction. Before, during, and after.